ladies and gentlemen, we now move to our live Q&A panel. You can see them joining me on screen with their lovely smiles and waves. Thank you to Dr. Holliday, Dr. Dorth, and Dr. Du for joining us for our live Q&A panel as part of this event. Thank you so much for being here and taking the time. We really appreciate it. If I can turn to our first question, which is open to all the panelists, what can patients do during and after chemotherapy and radiation to support their immune system?
Yeah, that's a great question. Of course, that's so important that we really monitor patients when their blood counts are low during treatment, and then in the recovery period, we monitor very carefully for any fevers, prompt care for any fever, going to the emergency room right away, getting antibiotics, getting a workup. That is life-saving and has really changed the quality and outcomes for treatment significantly. Also important just in that recovery period, really, as a lot of thrivers have said today, really take care of yourself, really protect yourself while your immune system is low, trying to avoid infections as best possible. Good nutrition is critical and certainly helps with that recovery process. So we really focus on hydration and nutrition too.
Thank you. If I turn to the next question, can one of you speak to the ideal surveillance immediately after treatment? So in addition, what follow-up or surveillance is recommended in the months or years after 5-year survival? I don't know if Dr. Holliday or Dr. Du wanted to take that one.
And Emma, I know you led the effort on that for the ASTRO guidelines, really coming up with the best surveillance practice, and so grateful for your leadership on that. It's very helpful.
Oh, it was a team effort for sure. And it's a tricky question because if I understood the question correctly, it was after the 5-year mark. What should we be doing for surveillance and survivorship? And we don't have a lot of great evidence about that. If you look at national guidelines or even ASTRO guidelines that we put together, most of the evidence informs the surveillance strategy up to year 4 or year 5, but doesn't give us a lot of guidance on what to do after that. And part of that is a good thing. It's good news that usually after year 4 or year 5, the risk of recurrence is extremely, extremely low, and not enough to support any specific evidence-based surveillance strategies. So, I can speak to what I do personally. Patients who want to continue on surveillance, I'll continue to see them annually with a good history and physical, and we will do targeted imaging or other studies kind of based on symptoms or specific issues, but not a lot of great data to support any one strategy after year 5. I don't know if any of the other docs have thoughts.
I'll add to what you're saying, Emma, and first of all, thank you for all the patients who are participating. Your comments and questions are really very insightful, thought-provoking, and meaningful. And as a physician treating anal cancer, that's really a very important thing to see for me. You have with Dr. Dorth, Dr. Holliday, some real-world experts here with anal cancer, and so this is I'll just echo what Dr. Holliday said, which is most patients have, will recur before year 5, and after year 5, the chances of recurrence are quite low. However, I agree, annual surveillance is something I like as well, and actually less so for the risk of recurrence and more so actually for what a lot of you are actually commenting on, which is long-term surveillance and follow-up with side effects of radiation, which is very important for radiation oncologists to, as the comments are showing, take ownership on and advise with, and making sure that that's being paid attention to and that we're taking care of you in the long term.
Thank you, Dr. Du. I think to expand and inform the next question there, are there any lifestyle changes that can support improved outcomes during treatment, such as diet and rest? It's something that I think you've heard from some of our thriver stories today, but would love the panel's thoughts on that.
Well, I'll jump in since I'm the only unmuted person, but please, of course, again, we have world's experts here. So I think across the board, exercise is actually much more important than we ever thought it was, and this is being shown in clinical trial after clinical trial. And I think it's something that as we think about how we can improve long-term cancer outcomes, not only in terms of function of patients, but survival, that really, I would say, structured exercise programs are becoming more important and recommended. And I don't know, Dr. Holliday, Dr. Dorth, I'm starting to talk to my patients much more routinely about not just this kind of vague guidance of get more exercise, but really being specific in terms of recommendations.
No, I agree. We're doing similar, the good guidance on eating the rainbow, on moderating alcohol intake, on moving your body daily, or if not daily, as close as you can get, is great for overall health, and it's great for cancer survivors as well.
Thank you, Dr. Holliday. And I actually have a question for you here. If patients did not use a dilator before or immediately after treatment, can they be a useful tool now?
I think the answer is probably that depends. I think if we look at the tissues and how they respond after radiation specifically, a lot of the fibrosis or scar tissue will form by about year 2 or year 3 after finishing treatment. And there may not be quite as much benefit in preventing scar tissue formation with using a dilator. However, I do have patients that come to my practice and for whatever reason could not or did not utilize the vaginal dilator in that ideal window, still find it helpful. And some of my patients find it helpful even in preparation for vaginal intercourse, if that is something that they're doing. So it can be helpful in, reducing the pain with penetrative vaginal intercourse if kind of used appropriately. So yeah, you may not get the most benefit if you're starting it beyond that window, but I think it's worth a conversation. And I know I work with several pelvic floor physical therapists who are wonderful, and I refer a lot of my patients to them, both within the window and outside the window, to kind of get some guidance or even some hands-on tutorials on how to use those most effectively.
Yeah, I'm seeing, that's super helpful. Thank you, Emma, for all of that. I'm seeing a lot of questions in the chat just about the frustrations and people pointing out that really us as radiation oncologists, this hasn't necessarily been first and foremost on our radar, and we're not really experts necessarily in how to use the dilators, and maybe not the best supporting patients and educating. So certainly seeing a pelvic floor physical therapist can be extremely helpful. Using it several times during the week, 2 or 3 times a week, 10 to 15 minutes. But pelvic floor physical therapists can really work with patients one-on-one, really understand, well, where is the whatever scar tissue, where is the source of discomfort, and really target stretching and dilator use to that patient. So I really wish we were better at this as radiation oncologists, and so important for this summit today and all of you participating and all your questions. Certainly we as providers need to learn from you how to be better.
I'll just add as well. I agree. We need to be better at this. One of the things which I'll just echo, pelvic floor rehabilitation is so important. Also, another, I would say, growing trend in the country is really the SIMS clinics, which are very helpful. These are sexual intimacy menopausal clinics that are really directed toward patients and very helpful for cancer survivors and improving pelvic floor health. And so if these things are available to you, please seek them out, ask about them from your physicians. I'll share that many times patients are frustrated about the lack of response from their physicians. One patient, I'll just share an anecdote, is, when I was first starting off, maybe my first year of practice, a patient who I didn't treat, but one of my medical oncology colleagues referred back to me, thankfully, had been really suffering for years with pelvic floor symptoms and not getting any traction, any response, any help. And all I did was send her to, again, a pelvic floor specialist that we worked with. And, about 6 months later, she said she was noticing improvement. About a year later, she was feeling quite well. And about 3 years later, she asked me if she needed to keep on coming back to see me. And, this is kind of a best case scenario. Of course, not everybody is going to have this kind of really fantastic response. But it does show that it can happen, and that, we can help, and we want to try to help.
Thank you. Dr. Dorth, you talked about the conversation in the chat, and I see you've been getting involved in that. So thank you so much for that. To draw out one of those points, could the panel speak more to tools to use to alleviate skin discomfort during treatment, making sure the skin is there, using sitz-baths has been mentioned. Could the panel touch on what else it could be useful?
Yes, no, thank you. I appreciate all the great comments, and my sincere apologies. I realized that there was the typo in my slide, and definitely would recommend getting air to the skin as much as possible during treatment to promote healing, and also protecting the skin using, people have said that bidets were helpful, sitz baths, wet wipes, all of that is helpful as opposed to dry toilet paper in terms of preventing irritation to the skin after bowel movements. Yeah, I think, a number of things that can be helpful, and really communicating carefully with your oncology team during treatment. Things change day by day, hour by hour, and coming up with a plan in advance, of course, is part of the weekly meetings you have with your treating team, but also really communicating back to your team what's happening. Certainly regulating bowel movements, taking antidiarrheals for frequent bowel movements, that can certainly help the skin. Being physically active, like Kevin was talking about, and getting up, moving about, good nutrition, using creams, barrier creams are really helpful to protect the skin. But a lot of patients do have significant pain at the end of treatment, and we as providers need to be really mindful of that and manage your pain appropriately. So it's an important discussion between the patient and the team, really what are the best strategies day by day to manage these side effects that increase toward the end of treatment.
Thank you. From a data point of view, just in something else that's coming through the chat, do we have any statistics on how many people experience long-term or chronic radiation impacts versus how many fully recover with no long-term chronic impacts?
We don't have as much data as we'd like. The way studies are designed and funded, to be honest, often the most attention is paid in the first 2 years. Because we want to know if we get people to cure, if we get them to be cancer-free. We want to see kind of how they're doing during radiation, because those side effects are really easy to kind of assess and measure on a clipboard. The long-term follow-up, even for studies that try to do it, kind of falls falls off the cliff a little bit. So I'll start my answer with an acknowledgement that we would like better data. And I think the studies that are certainly being designed now, or even that are underway, are a little bit more mindful about that and using patient-reported outcomes rather than kind of a physician with a clipboard assessing what true recovery means, because us doctors are not very good at that, right? We would rather hear it from the folks' own words. So with that caveat, the data that we do have would suggest that probably somewhere in the neighborhood of 2/3 to maybe even 3/4 on some studies never get back to that pre-treatment baseline. It's a wide range of what the kind of long-term or permanent changes are that folks are experiencing after treatment. It could range from a person may be a once-a-day pooper after they have their coffee, like clockwork, very regular. And then 5 years after radiation, they're now having to go 3 times before they leave the house, and it's a little more unpredictable and it's a little more urgent. On the worst end of the spectrum, a smaller percentage of folks may have even more disruptive changes that are permanent or persistent. So from what I've read and from the kind of survey studies I've done with my own patients, it does seem like a significant number of patients are not getting back to 100% of where they were pre-treatment. And it does go to show and is an inspiration for a lot of the current and hopefully upcoming studies to intervene and to move that needle and to bring that percentage down.
Thank you. Again, just going through what we're. Thank you to our attendees as well. Please do keep your questions and points coming. We'll try and get to them all. If we don't, we'll try and answer them after the event. What suggestions does the panel have for the management of long-term damage to the hips or bones from radiation therapy? How is bone damage identified?
I can speak to what we do in my practice. So we routinely start checking bone density somewhere between 6 and 12 months after treatment is done, because we do know radiation to the pelvis can reduce bone density, cause damage, and increase the risk of what we call insufficiency fractures. So we do the bone density scans not to really find the damage, but to help identify people for whom we can make an intervention, right? We can either recommend vitamin D and weight-bearing exercise if we're on kind of the lower osteopenia side of the spectrum, or folks that do have osteoporosis and have decreased bone density to a more severe level, we can make referrals to endocrinologists who can talk about prescription medications to help improve bone density. I'd be curious to hear what other panelists are doing. I do not routinely order any specific scans to assess for bone damage. Certainly if a patient comes in and they said, man, my hips or my low back are really hurting and this is different or it's getting worse, then, sometimes we can see insufficiency fractures on the CAT scans we already do for surveillance. And if there is pain that is not explained by the CAT scan, I will personally sometimes get an MRI, and that can sometimes show us these little insufficiency fractures that are not well seen on CT. But I don't have a specific screening regimen to screen for bone damage, just increased bone density that will then act to try to mitigate, if that makes sense.
Yep.
Yeah, I think
we have so much to learn as radiation oncologists, and thanks to you, Emma, I am now recommending screening for bone density loss after radiation for my patients. But thank you we all need to learn more about these long-term risks, and thank you for the opportunity to discuss these things and learn from each other.
Yeah, I'll also add,
please.
Dr. Dorth, your presentation was, I think, very insightful that we're paying more attention to exposure of the bone marrow and bone with higher doses of radiation and trying to mitigate this risk in the long term as well. So it's something where we're trying to learn and improve here. I think this is kind of to Dr. Holliday's point, where a lot of the long-term side effects of radiation, we do need to do a lot more research on. A lot of the things that we're doing are kind of interventions that are things that we would use for, what folks would go through anyway, management of osteoporosis that people have. And these are the interventions we use for radiation-induced osteopenia and insufficiency fractures. This is where we need to do a lot more research in terms of the long-term effects of radiation and specific interventions which may help. And again, Dr. Dorth, to prevent these things from happening. Thanks.
Thank you all. The next question we have, for how long is ctDNA testing recommended during and after treatment?
I think to be continued. That has not made it yet into the current guidelines. It is a hot topic of conversation. And I think the trickiest part, at least in my practice discussing with patients, is we have now tests that we don't really know what to do with the answers, right? I think it's very easy if we get a ctDNA test, let's say we start them, 3 months after treatment's done, and we'll do them at every follow-up. And it's very easy if they're negative. It makes us feel very good, like, hey, your scope looks good, your scan looks good, your ctDNA looks good. What do we do when it's positive? And we don't find the place it's coming from within the body, right? We don't see it in the anal canal, we don't see it in any lymph nodes, and we don't see it anywhere distantly. Right now, we don't really have any guidelines supported or evidence supported treatments for positive ctDNA without an accompanying clinical recurrence or recurrence we can see. And that's very, very frustrating. So there are some of us that are trying to work in this space and open trials to investigate treatments, because I think none of us would want to sit on a positive ctDNA test. But right now, we don't have great evidence of which treatment to do and how much it helps. So to be continued. Maybe we have more updates at this summit next year.
Yeah, looking forward to the presentations this afternoon about HPV ctDNA, going to be extremely helpful. In my practice, have that conversation that with patients that you so nicely describe, Emma, and I find it is helpful to measure at baseline to determine if ctDNA is detectable at baseline. There are some tumor types where there's just a low copy number of HPV and it's not even positive at baseline. So then really, what is the value of it in follow-up? So in my practice, I offer it at baseline for interested patients. We really don't know. We don't know what it means in follow-up, of course, or during treatment. So I don't check it during treatment as standard of care. And I start to think about checking it around the 3-month mark and maybe every 3 to 4 months for the first few years. Like was mentioned earlier, it's really the first 2 to 3 years when we really want to most intensively survey patients to make sure there's no concerning signs for cancer recurrence. So that would kind of follow that maybe ctDNA is most helpful during that time to be doing frequently, maybe less frequent after that time. But yeah, we definitely need more studies in this area to better define things. We don't know what to make of a positive test result, of course, but I have found that, of course, if we get a positive result, we don't want to sit on it, and we are doing more intensive scanning after that, more frequent exams. So if it is positive, it does change how we're monitoring, although it is causing a lot of stress to patients, of course. And so really, it should be a doctor-patient decision. Do you want to do ctDNA surveillance?
A great point. Some of my patients don't want to because it's not actionable. Yeah, it's certainly what we call shared decision making at its finest, or should be.
Dr. Dorth, do you use NavDx when you're saying before which ctDNA platform do you use?
Yeah, we've been using NavDx. It is approved by Medicare. And many private insurance, I would say most private insurance companies kind of follow suit and will cover it. Naveris is very supportive and will work with providers who are ordering the tests as well as with patients. And they can offer some financial counseling. It's really across hundreds of patients, we've really only had coverage issues come up a couple times for patients. So we
Yeah.
find the vast majority of patients would be doable with their insurance.
Yeah, I think this is a very important research space, of course, and a very hot topic, as with many cancer sites. And to your point, I think you had presented that the next generation of anal cancer trials would certainly include a component of this. I know it's an important question because every single one of my patients asks me, how is the cancer treatment going? Is the cancer responding? Why do I have to wait 6 months after chemoradiation to know if the cancer is gone? These are very important questions that ctDNA may help us solve in the near future.
Yeah, and as Dr. Dorth pointed out, we will be covering ctDNA in a later section this afternoon. So hopefully some of those questions will begin to be answered as part of those presentations. So yeah, glad we'll be able to be bringing hot research and topics to the forum today. We're receiving questions from people who are 5 to 15 years out, stating that their radiation symptoms seem to be getting worse, from urgency to bladder incontinence to pain. And we heard that there are no routine recommendations at this time, but it sounds like from our panelists that even years after treatment, pelvic floor therapy may be helpful. So if we don't have routine recommendations, based on your knowledge, which physicians will be most knowledgeable to help address some of those current systems that thrivers are experiencing?
So wide range of symptoms, right? You said pain and urgency, incontinence, and there was another one in the list.
Urgency, bladder incontinence, pain. Yeah, that was it. Those were the three.
Yeah, I think pelvic floor can be very helpful for both bladder control issues as well as frequency of bowel movements or urgency or difficulty controlling bowel movements. So I think I will personally make that referral or recommendation, no matter where a person is in their survivorship journey. Pain is a little bit more difficult, and I think people can have pain after treatment for so many different reasons, right? Folks can have either tightness or muscle contractions or spasms that can be painful. There can be irritation or maybe even some ulcers or fissures within the anal canal that can come from bowel movements passing through areas of scarring or stenosis. And the treatment of pain is very different depending on what the cause is. So my first go-to as a physician referral is if the person is not still in contact with the colorectal surgeon or a gastroenterologist, if they're so far in survivorship, they haven't had a scope recently, that can be a helpful first step to look for the cause of the pain. Because if there's late radiation proctitis or irritation, that's one set of treatment option. That's one toolbox we'll reach for. But if it's a fissure, we would do something else. And so I think that's usually my first go-to for anal pain that either persists or comes up later in survivorship. But for control of bowel or bladder, I think, I have also seen pelvic floor PT be life-changing. So that's my first go-to referral in that scenario.
I mean, if I can come in just at this point, one person in the chat mentioned that in Europe, there is some recognition as pelvic radiation disease as a diagnosis and has clinics with specialists involved. And is there any effort to have PRD clinics in the US for long-term impacts that you're aware of?
I think it's a fabulous idea. There aren't any that I'm aware of, but I think it is a massively unmet need.
Yeah, I'll say when I was practicing in New York, there was one of the physical medicine rehabilitation physicians had actually specialized in radiation effects and rehabilitation. That was incredibly helpful to be able to send my patients to someone with that kind of expertise, because even though I deal with radiation side effects all the time, a lot of times it's a team effort to try to help patients. So I think that kind of recognition is building, and there's a lot of opportunity there, in terms of helping with that. The way I look at long-term radiation side effects is there's two components. One is maladapted healing response, and sort of a microscopic scar tissue and compromise of blood flow. And the other can be a long-lasting inflammation. And both of these are really kind of things that also happen with trauma, where there can be a poor wound healing. So sometimes sending patients for wound healing, and there are clinics, certainly, even if there aren't radiation-specific clinics, there are many wound healing clinics that are helpful.
Just as a follow-up, Dr. Du, what is the role of hyperbaric oxygen therapy for long-term side effects? Is it generally covered by insurance?
I practice in Texas, and I know there's a lot of state-to-state rules. We have a hard time getting it covered here. I think I have used it with some success for long-term bleeding. So radiation proctitis that's causing kind of this constant ongoing bleeding picture from inflammation. I've been able to order it and have it covered successfully for that as a specific indication. Also for bladder bleeding or bleeding in the urine that presents a couple years after treatment. I personally have not had any other kind of success stories of helping people to access it, but it's very location specific across the country, and I'm sure between countries as well.
Just want to mention, I really wish we had dedicated clinics to really address these radiation specific concerns, but just want to point out nice to see some success stories in the chat. Talking about seeing integrative oncology, I would say in particular, can be very helpful. Integrative oncologists really think outside the box. They can talk about supplements. They can talk about, my son says hello to everyone. So integrative oncologists can really think outside the box. What can we do long term? Is a chiropractor, is acupuncture helpful? Also, I would say we have many more clinics really working on pelvic floor function. So urogynecologists, urologists, many sexual function clinics from gynecology have also been helpful too. So really kind of thinking broadly and trying to tap into some of these other resources hopefully could be helpful.
Brilliant. Final question for our panelists. This has been absolutely scintillating stuff. So thank you so much so far. How can the palliative care team play a role even when diagnosed with early stage anal cancer? When should the palliative care team be engaged? How can they be helpful?
I think they can be extremely helpful. These are doctors that are specifically trained and expert in kind of symptom management and helping people feel better. And who needs to feel better more than people getting treated for anal cancer? So at my hospital, we will make referrals early and often, even beyond pain control. Sometimes they have good, I learn from them strategies or tips and tricks on managing diarrhea or using a side effect of one medicine to also cover another symptom. So yeah, I think the branding of palliative care, sometimes people don't like the way it sounds because they say, what does that mean you think is going to happen to me? But the way I explain it in my clinic and the way I think of my colleagues in palliative care is they're really experts in helping people feel their best and managing symptoms. So they're a great partner, both during and especially kind of that immediate post-radiation time, I think.
Brilliant. Well, ladies and gentlemen, I'm afraid that session has absolutely flown by. I'm so grateful to our participants for submitting the questions, but also our wonderful panelists, Dr. Dorth, Dr. Du, and Dr. Holliday for their thoughts and energy as part of that. So, ladies and gentlemen, we'll take a short break, and we will return at 1:45, so in just under 5 minutes' time. So, chance for a bathroom break, grab a refreshment, and we will see you very shortly. Thank you again, wonderful panelists. That was fantastic.